Hello everyone. Last class we studied anatomy, imaging, and special physical examinations of shoulder and elbow. Today we will begin to learn about specific orthopedic disease of shoulder and elbow. I hope everyone can combine the previous anatomical knowledge with the content to be learned later, achieve integration, and master it comprehensively. First, let's look at the fracture of surgical neck of humerus. The surgical neck of humerus is located 2 or 3 cm below the anatomical neck and above the dead center of pectoralis major, where the transition from the cancellous bone to compact bone is relatively thin, which is a weak link in anatomy. Fracture is common here and can occur at all ages, especially in the elderly. So, what causes fracture of surgical neck of humerus? Both indirect and direct violence can cause fracture of surgical neck of humerus. Based on the injury mechanism and fracture displacement, it can be divided into the following 4 types clinically. First, fascial fracture. Direct violent strikes on the lateral side of the shoulder, or falling and collision, result in comminuted fracture of the greater tuberosity of humerus and fascial fracture of the surgical neck, mostly without displacement. Second, abduction fracture. When falling, the upper limb is at abduction position, so that the distal segment of the fracture is abducted, and the proximal segment is correspondingly adducted, forming angulation displacement of the 2 fracture ends to the outside, accompanied by the mutual impaction of the 2 fracture ends. The proximal end of fracture is pulled by supraspinatus and infraspinatus, showing slight abduction and lateral rotation displacement. The distal end of the fracture is pulled by latissimus dorsi, pectoralis major, and teres major, and displays inward, forward, and upward to the lateral side. The 2 fracture ends are impacted laterally and separated from the medial side, which is often accompanied by greater tuberosity fracture. Third, adduction fracture. When falling, the upper limb is in the adduction position and pulled by muscles, so that the distal segment of the fracture is adducted and the proximal segment is correspondingly adducted, forming angulation displacement of the 2 fracture ends to the side, and the 2 fracture ends being impacted in the interior side and separate in the lateral side. Fourth, fracture of surgical neck of humerus combined with shoulder dislocation. Most of them are shoulder dislocation caused by abduction and lateral rotation violence of upper limb. When the violence continues, it results in humeral surgical neck fracture. Clinically, based on the patient's injury history, combined with obvious pain and swelling, pain worsens after activities, obvious tenderness around the greater tuberosity of the humerus, and X-ray examination of the shoulder, the diagnosis can be confirmed and the type of fracture can be shown. In terms of the treatment of fracture of surgical neck of humerus, aggregate reduction, firm flexation, and early functional exercise are the most important measures. No reduction is needed for fracture without displacement or fracture with slight displacement, especially for the impacted fracture of the elderly. Early the triangle bandage should be used to suspend the injured limb and strengthen functional exercise. For displaced fractures, manipulative reduction and external flexation should be performed. The specific steps are as follows.
Manipulative reduction of fracture of surgical neck of humerus. Take adduction fracture as an example. The operator pushes the outer side of the fracture inwards with both thumbs. and pulls the distal end upwards with other forefingers. The assistant plucks the upper arm under traction. If the anterior angulation deformity is significant, lift the upper arm over the head. At this moment, the operator stands on the anterolateral side of the patient, pushes the distal end with both thumbs, and presses the angulation protrusion with other forefingers. If there is a bone friction feeling, and broken ends resist each other, the angulation deformity correction is indicated.
For fracture of surgical neck of humerus combined with anterior shoulder dislocation, the treatment sequence of dislocation and fracture should be decided based on the specific injury condition. Surgical treatment should be considered as early as possible if the fracture of surgical neck of humerus is displaced seriously and the manipulative reduction is unsuccessful, or the manual reduction cannot be achieved due to delay. Emergency surgical repair should be performed for patients with nerve and blood vessel injury. After fracture flexation, it is feasible to relax and contract muscles of wrist and elbow joint at an early stage. In 2 or 3 weeks, abduction activity should be limited for abduction fracture, and adduction activity should be limited for adduction fracture. And the shoulder joint activities in all directions should be started after the external fixation is released for 3 or 4 weeks. Next, we will continue to explain supracondyle fracture of humerus, refers to the fracture within 2 centimeters above the medial and lateral condyles of distal humerus, which is mostly occurred in children aged 5 to 12 years. Then let's look at the etiology and pathogenesis of supracondyle fracture of humerus, mostly occur in sports injuries, life injuries, and traffic accidents, generally caused by indirect violence. Generally, it is divided into strange type, strange ulnar deviation type, strange radial deviation type, and flexion type. First, the strange type, when falling. The elbow joint is half flexed with the palm on the ground. The reaction force of the ground is transmitted to the lower end of the humerus through the forearm, and the proximal end of the fracture is displaced forward, while the distal end is displaced backward. The fracture line passes obliquely from the rear upper part to the front lower part. Serious displacement often causes injuries to bronchial artery, median nerve, and radial nerve. The strange type is divided into ulnar deviation and radial deviation type. The external force is from the anterolateral side of the condyle of the humerus. When the distal end of the fracture is displaced to the ulnar and posterior sides under this force, ulnar deviation occurs. The median ball is compressed and the lateral periosteum is intact. Fracture displacement must be reduced to avoid cubitus varus deformity. However, the radial external force comes from the anteromedial side of humeral condyle, which causes the distal end of fracture to move to the radial side and posterior side. So, cubitus varus deformity is generally not easy to occur. Secondly, flexion type. Elbow is mostly in the flexion position with posterior elbow landing on the ground. External force is from bottom to top. Or lateral node of ulnar impacts humeral condyle directly, resulting in supracondyle fracture. The distal segment of fracture is placed forward and the proximal segment is displaced backward. The fracture line is inclined from the anterior superior to the posterior inferior. Next, we will look at the main clinical manifestation of supracondyle fracture of humerus, mainly including elbow joint swelling, dysfunction, obvious tenderness, limited to the upper part of humeral condyle, but the posterior cubital triangle is normal. A feeling of bone friction and abnormal activity may be detected. It can be clarified and diagnosed by X-ray. Finally, it is the treatment of supracondyle fracture of humerus. The anatomical reduction is not only mandatory for traditional treatment of supracondyle fracture of humerus, which takes alignment as the criterion. However, the increase or decrease of the physiological adversion angle of the distal fracture after manipulative reduction can lead to cubullus varus or valgus deformity. Therefore, both surgical and non-surgical treatment should avoid aggravating soft tissue injury and give good reduction. Generally, we can take manipulative reduction first. For children with supracondylar fracture of humerus without displacement or with slight displacement, the upper limb was fixed with plaster abduction frame, and then they should come to the hospital regularly for observation. For children with severe displaced supracondylar fracture of humerus, manipulative reduction, ulnar or lateral traction and plaster abduction frame fixation should be performed. The specific steps are as follows.
Reduction and fixation of humeral supracondylar fractures. Hold the patient's forearm back. Slightly bend the elbow. Perform traction by pulling and extension. Correct ulnar deviation at the distal fracture, and by resetting manipulation. Correct posterior displacement at the distal fracture and by lifting manipulation. Bend the elbow 90 to 120 degrees and leave a small splint. Pay attention to prevent cubitus varus during reduction. Pay attention to the position of pressure pad and the tightness of horizontal bandage during fixation. After fixation, observe the distal blood supply of the affected limb.
After successful reduction, reliable fixation should be adopted as soon as possible. Common fixation methods include: first, splint fixation. The length of splint should reach the middle level of deltoid and exceed elbow joint at the lower end. The anterior and posterior splints of stretching fracture are 90-degree curved, while the anterior and posterior splints of flexion fracture are 13-degree to 45-degree curved. Among them, for the stretching ulnar deviation type, Tower pens suitable for local shape should be placed on the lateral side of the proximal end and the medial side of the distal end of the fracture. For the radical deviation type, pressed pens are generally not placed in the medial and lateral side. For strange fractures, a flat pen can be placed at the proximal end of the fracture and a trapezoidal pen can be placed at the posterior side of the distal end. For flexation fractures, a flat pad was placed on the posterior side of the proximal end, but not on the anterior side of the distal end. For strange fractures, the elbow joint should be fixed at 90 degree to 110 degree flexation position for 2 or 3 weeks. For flexation fractures, the elbow joint should be fixed at 30 degree to 45 degree flexation position, and then changed to 19 degree flexation position after 2 weeks. The flexation time is 1 or 2 weeks. Second, plaster fixation. For those without displacement fracture, with local swelling of fracture and skin tension vertical, they can be fixed with plaster support or U-shaped plaster on the medial and lateral side of elbow. Surgical treatment should be considered in the event of failure of manipulative reduction or combination of vascular and nerve injury. Finally, there are several points to be noted for supracondylar fracture of humerus. First of all, if the fracture is not handled properly, it is easy to be complicated by cubitus varus deformity and forearm ischemic contracture, so we should strictly prevent it. Secondly, start functional exercise after fracture reduction and fixation. Patients should be encouraged to do more activities such as clenching fist and wrist fixation and extension. After external fixation is released, elbow flexion and extension should be actively exercised, but violent passive activities should be strictly prohibited to prevent myositis ossificans. Well, this lesson is over. I hope you can combine the knowledge about anatomy and imaging of the shoulder and elbow for reviewing. Thank you.